Well, let's kick off, and we are recording the session, so anyone who's kind of late can catch up with the recording. So just a huge welcome to the Community Mental Health Transformation Monthly webinar. Lovely to see you all here. Um, just to say, yes, the webinar has been recorded today, and it's going to be added to our YouTube playlist. So if you prefer to do turn your camera off and anonymize your name. If you'd like to turn on live captions, just click the three dots that say more in the toolbar of your screen and go to language and speech, and then just select the turn on live captions. There's going to be plenty of time for Q&A at the end of presentations. So if you'd like to submit any questions in the chat box, or just raise your virtual hand, we want everyone to get involved and be part of the conversation. And at the end of the webinar, I'll just email you a short survey to let us know what you thought and how we could make it better. I haven't introduced myself. My name's Alice. I work in the comms team at Sussex Partnership. That was a slip there. I've only been at Sussex Partnership for about 2 months, previously worked at Southdown, and I'm comms support for the transformation programme. So it's lovely to see you all. Okay. Just to say, these webinars have been running for a while now. So if you want to watch any back, then this QR code will take you direct to our playlist on YouTube, so you can watch any back or share them with colleagues that might want to get a bit more up to date on what's going on across the community transformation programme. I will share these slides at the end of the webinar, so you've got that QR code in the chat. And so a warm welcome to our presenters today. We've got system-wide representative Penny Fenton, who's Senior Programme Manager at Sussex Partnership, and Martin Dominey, who's the VCSE Mental Health Transformation Lead for Brighton and Hove in East Sussex. So Penny and Martin will be giving a central kind of system-wide update. And then a really warm welcome to West Sussex representative, so Mary Linda Garoro, who's a Service Manager in Chichester at Sussex Partnership, and Susie Mulhern, who is an Operational Manager at BHT Sussex. So thank you so much, guys, for coming along and kind of getting involved. So Martin, I'm going to hand over to you to give a bit of an update on just a reiteration of that. Why are we transforming and what's going to be different with Neighbourhood
Yeah.
Mental Health Teams? So over to you, Martin.
Great. Thank you so much, Alice. I think we often can describe the kind of community transformation program as kind of a once in a lifetime opportunity. There are always kind of focuses on particular parts of the system, but often community has been the one that's kind of just kind of emerged and kind of formed kind of over the years as well. So it's a fantastic opportunity we've had kind of before us really to really start changing things for our kind of community services as well. We appreciate that kind of many of you are trying to join these meetings or these webinars on a regular basis as well. So I will keep this as a brief overview and context setting as well. But just we will always want to make sure if there are new people join in that we do have an opportunity to set some context for everybody as well. What we do know and what kind of people tell us and what we've kind of picked up through kind of the workshops and the kind of the events that we've run over the last couple of years as well. We know services are really overstretched. We know people are dissatisfied about how long they have to wait for services as well. And we know that it's a complex kind of landscape to navigate for people as well. There's many providers doing sometimes similar things or very different things that aren't coordinated as well. So I think it's a real opportunity for us to really start to work differently together in a much more integrated way, much more integrated in terms of our primary health kind of colleagues into what we used to call secondary services or clinical services, but utilising the resource and the providers within the VCSE as well. So we really want to make sure that this does really have an effect that is really positive that comes out of this. We want to see much more improvements for kind of people using our services for carers and families as well, making it easier for them to use, making it quicker for people and not have to repeat kind of same processes as well. So we know sometimes people may receive support from a number of organisations and they're going through very similar processes each time they come into touch with them as well. So we kind of want to make sure that it's actually much more linked up and it feels much more kind of together and kind of coordinated for people as well. For staff, again, we want to kind of really kind of make sure that, again, using the example of kind of assessments as well, knowing that there is one assessment, that everybody kind of is aware of that could be used to really kind of build that individual tailored support for that person as well. And we kind of come, there's really good relationships with all our services already, but we want to kind of increase that and kind of build on that. We want people to sit next to each other, to talk to each other, to making sure things do really feel really supportive. And we are coming across as kind of one team, regardless of different organisations as well. But overall, we want to make some really kind of, stark improvements in terms of what resources out there. We know there's limitations. We know there's real pressure around kind of financial kind of landscape that we're in at the moment. So it's making sure that we really do address kind of some of those kind of needs that people need us most as well. But also, so how we can change the system, our cultural change, but how we can obviously support people not to kind of, need that crisis and inpatient support, if we can start to work in much more joined up, much more kind of preventional approach as well. So, yeah, it's a really good opportunity. It's complex, we know, and sometimes it can feel slow moving as well, but there's real commitment, for everybody that we're working with, people that use services and other providers as well. It makes logical sense to make the most of us, most of what we have, and to make that kind of outcomes and experience for people using services better. Thanks, Alice.
Fabulous. Thanks, Martin. Okay, we're going to hand over to Penny to talk a little bit about the readiness checklist to kind of fully mobilise. What you on mute, Penny?
Apologies, everyone. As Martin has said, progress around the rollout of the neighbourhood mental health teams is different in all of the different areas, and that's because each area, so East Sussex, West Sussex and Brighton and Hove, all started in quite different places. And as we know, different areas had to change the boundaries of their teams to reflect what's going to be the new integrated care teams, which is the wider social care piece of work that's happening across Sussex, and that's how they're going to operate. So, and that's taken a little bit of time in terms of making sure staff and resources and records, etc., are all in the right place. And they are pieces of work we continue to work on. And we also are introducing a new electronic patient record. So the electronic patient record that we currently use within Sussex Partnership is called Care Notes, for people who don't know, and it's been phased out. It's not going to be supported nationally anymore. So we're introducing a new system, which is System 1, which is another system that's used by about 50% of our GPs and will be used by Sussex Partnership, and will, in its optimisation, have links to the other systems that the other 50% of GPs in primary care use. So there's a lot going on in the background. And what we do know is the bringing together of that shared system is really supportive of being able to roll out this more integrated way of working. So, for example, people in the core team being able to ensure people are worked with in partnership to have a single care plan, rather than having one for here, one for there, being referred over here, back to somewhere else and back again, which is one of the issues that people absolutely rightly raise, that things are complex. But because people are starting from all different spaces, we sort of had to work back from where do we need to get to for each of those teams to be able to, in essence, mobilise and feel like they're safely mobilising. So as I say, it is a progression, and this is taking place over a period of time. So if you can move on to the next slide, please, Alice. So there are areas on that checklist which includes making sure it's really clear that management and leadership structure are agreed for each of the 15 neighbourhood mental health teams, and that those staff are in place across both the Sussex Partnership Trust, the NHS and the voluntary sector services. That's really critical, so we can really ensure that we're supporting all of those processes and we're ironing out all the difficulties that we need to iron out as we start to move towards this whole system working. So that nitty gritty on the ground floor, how do you actually do it? How do you bring this to life? What are the agreements we need to ensure are in place to do that safely and do it well? And of course, we know staff that have really good supervision and are very clear about their line management arrangements perform to their absolute best ability. And so we need to make sure, not that it isn't now, but just to ensure with those new boundaries that that's absolutely continuing in and in place for each and every team. And we need to make sure some of our meeting structures are set up. So we've discussed a range of meeting structures to support integrated and partnership working. And they're fundamentally meetings that are safely held in a multi-agency way to help people right at the beginning of coming into a neighbourhood mental health services team, to make sure we can get people to the right help first time without that bouncing around the system that we spoke about, and reduce those feelings of having what's sometimes termed unhelpfully, I think, at the moment as a rejected referral. So people do get to the space they need to get to. There are also broader multidisciplinary team meetings which will have wider partners such as the voluntary sector for much of the same reason. So as things progress with individuals and their needs might change, there's an ability to reach both clinical and non-clinical services in the same space to try and work out how we can best support people, of course, based on their consent and the needs that they require and have both and of course asked for, and to make sure they're working really, really successfully. And the third one is really a space to ensure that we've got a process in place to be able to work really well with our primary care colleagues. So making sure we have some increased presence in GP practice, because we know that transition gap is also a challenge for us in certain areas currently. So things fall between that gap of a GP thinking, oh, this individual really needs some help, and the services perhaps sometimes going, oh, we're not really sure how to help, or we need to send them back so you can refer somebody to somewhere else. And we know that's not particularly helpful for anybody. So we're really making sure those are in place in each of the areas. We also need to, of course, make sure people who are currently using our services, that they are aware of which neighbourhood mental health team they will sit under. For many, vast majority of people, it won't change. And where it does change, it will be the geography that changes, and even less so in some cases, but not many at all. Their lead practitioner or their name worker may change, but if and when they do change, it will be not when anybody's experiencing any sort of period of crisis and in full conjunction with those individuals. But that should be by far the minority. So this is a geographical change when we talk about the actual boundaries of teams as opposed to a care change. And of course, we need to ensure that GPs are really aware that they're referring, how they refer into the neighbourhood mental health teams. And we've been working on a new referral form to help with that, which includes a section about consent. So we're really clear with individuals, if they are being referred into the team, that what they're being referred into, so people can understand and make an informed choice about what they want and what they don't want. We've also got to configure our new data system. So I talked a little bit about the new electronic patient record system, as well as the most important function of it, making sure it safely holds clinical records. Its other function is to make sure we can understand things like, has everyone in the team had their mandatory training? How is our performance? What do those things look like? And at the minute, the current system has set those teams up as they are now. So as in ATS's, emotional wellbeing services, older adult services, very separate bits of the system. And the new electronic patient record system will bring them all together as a neighbourhood mental health team. So you'll still be able to get bits of data out, but fundamentally that performance information and that training information and clinical supervision record information, etc., will all be held on a singular system that we will be more able to access in terms of neighbourhood mental health teams. So at the moment, we've got the checklist, as I described in the first slide, that's out with each of those three areas, so East Sussex, West Sussex and Brighton and Hove. And each of those areas are kind of working through those. And there's some work to be done by the central team, so people like myself, Martin, other people on the call that are really looking at things that span the whole pathway. So things like agreeing the referral form, things like working with the electronic patient record system to make sure all of those structures are in place to support that safe and improved delivery of neighbourhood mental health teams. And between now and over the coming months, that we have a project plan of these must-dos that we'll be working through to make sure we reach that point of continuing to be able to improve and, I guess, fully provide fully functional neighbourhood mental health teams. But the work that's underway already won't stop as we're doing those things. So every area will all be working on setting up those neighbourhood mental health teams. There's some work also going on in the background around the care programme approach, which was a set of quality standards that are really old for mental health teams that we're now reviewing on the basis of national recommendations, and they will sit alongside this work as well. Thank you. I was going to ask to move to the next slide. Because this piece of work is really quite clear. So that's all the functions and all the processes and all the systems that we need to set up that we've previously described. And this bit is really around the quality standards that we need to put in place to support the delivery of neighbourhood mental health teams. And nationally, guidance has been, or draft guidance has been released under the guise of a personalised care framework. So the point of this is to replace the care programme approach, which some of you may or may not have worked with or experienced in the past. So across Sussex currently, we're looking at that personalised framework, the draft framework that's been co-produced nationally in Sussex, and we are sharing collective feedback for the deadline of the 23rd of May. And to let people know where we're getting that feedback from, we have a multi-agency, multidisciplinary CPA working group, and it's been through there to gather information. It's been out to East Sussex, West Sussex and Brighton and Hove divisions through Sussex Partnership. It's been out, it's going to a special scale expert by experience working group this Friday to make sure we're gathering all of that experience through as well. So we're getting it out to as many partners as we can. We're expecting the new finalised framework, national framework, in June. But again, the work we're doing in Sussex still continues in that CPA replacement working group. How do we localise that? How do we make it real? And how do we explore things that perhaps aren't on the draft guidance, that aren't contained in the draft guidance at the moment? And that includes things like how we operate virtual allocations. So things like multi-professional led clinics where people go and they are working with a group of staff rather than a very specific individual for all sorts of reasons. So we're working through all of those things so we can really make sure, as Martin talked about at the beginning, we're maximising the resources that we have, and we're making things as streamlined and as simple as possible for people to be able to come into services and work with the right person or the right service offer as quickly as we possibly can. And that will be wrapped up in the new personalised care framework, alongside things like co-producing care plans and making sure people feel much more in control and holding their own documentation and information. So that's where we are across the system. And we know that in West Sussex, there's been fewer boundary changes. So the boundary changes I talked about before have had less of an impact in West Sussex because the geography worked out well with the new integrated care teams. And for that and for lots of other reasons, and an amazing amount of work from West Sussex, there's been probably the most progression in the context of being able to then set up some of the meetings that we discussed before and some of the new ways of working. So helpfully, we've got Mary Linda and Susie with us today, who I will hand over to start to talk about some of this in action. Thank you.
Thanks so much, Penny. Mary Linda, would you like to kick us off with an update from West Sussex, and then Susie to follow? Does that sound okay?
Yes, thank you.
Fabulous.
So I'm just going to talk through the process that we followed. So our first step was to establish the NMHT planning meeting, which was attended by the ATS, OPMH, EWS, Pathfinders, Mind, professional leads from psychology and occupational therapy, and peer support. So having peer support was really important to us because we wanted to be guided by the patient's voice. We wanted to be responsive to our community's needs, and we also wanted to be mindful of any gaps in the service. From that meeting, we established our core team, and then we started our weekly MAT MDT meetings. We had a launch which went very well. We invited everyone, the third sector, secondary services, and the EWS. We also kept the GPs informed at every step, and they were invited to our launch. Our MAT MDT meetings are held weekly and provide an opportunity for cases to be discussed and allocated to the right part of the team. To make it easier for GPs, to make it easier for GPs to attend their bookable slots, because the feedback we got from the GPs is that they just couldn't attend a whole meeting, but that they would attend a bookable slot if it was available. The MAT meeting is also an opportunity for us to access advice, support, and expertise from the various organizations and clinicians in the room. After that, we established our daily huddles, which are 30 minutes long and provide an opportunity for urgent cases to be discussed, to work jointly, and for patients to be reallocated if needed. We already had our math meeting in place, which provides a forum for organizations like CGL, Talking Therapies, and other partners to discuss referrals coming into the ATS. We tried to establish a GP liaison meeting in Chichester, but the GPs declined this offer. We were able to establish a GP liaison meeting in Bognor, but the GPs in Chichester really didn't want this offer. They were very happy with the triage line, so they didn't want an additional meeting. The positives of working in an integrated way have been many, and there have been many opportunities to work collaboratively. So patients being referred to the NMHT no longer fall through the cracks because we come together and think of creative ways of reducing barriers and supporting patients. The process of moving a patient from one part of the team to another has become streamlined and straightforward. We don't have any referral forms. All we do is we gain consent from the patient, their case is discussed, and then we have a warm handover from one part of the team to another. Feedback from the third sector is that they're getting more appropriate patients than previously, so that has been a bonus. Feedback from patients is that they feel contained and supported as they move from one part of the team to another. Creating the NMHT has enabled us to do things together to improve how we serve our community better. As a neighbourhood, we've started on projects like suicide prevention in men and raising awareness about men's mental health. For the Mental Health Week, we're actually going to share a table with Mind at the Chichester Pride on Saturday. So there are many opportunities really to work collaboratively, to share costs, to share buildings, just to be aware of our community assets in the community. So we have found this process to be very positive. Thank you.
Well, that sounds incredibly positive. Thank you. Susie, do you want to come in and share a VCSE experience of developing neighbourhood mental health teams in West Sussex?
Sure, I'm trying to follow Mary Linda's amazing speech there. Just echoing what Mary Linda said, really, from the VCSE side of things, it's going very well established across the board with regards to the meetings. In different areas, people are working at different paces. So certain neighbourhoods, like Mary Linda mentioned, are getting GPs involved. They might be already attending meetings if that's an offer that they would like. Or in some areas, for example, I cover Crawley and Mid Sussex. So we're currently in discussions to arrange to start getting GPs involved in meetings. Some of the positive feedback that we've had from VCSE staff are mainly around managing risk, and so that improved support with managing risk with the daily risk huddles that we have with our ATS partners. So able to kind of like speak about clients first thing in the morning, and able to get some action in place, feeling a bit more supported from a clinical point of view, having those conversations daily. Also, another positive feedback has been the improved signposting across the board. So just shared knowledge. A lot of the VCSE staff are incredibly knowledgeable about what community services there are. Not to say that SPFT staff aren't also, but just having this shared knowledge and the shared space to when we're discussing in the, I'm going to get this right, MAT meetings, discussing cases and where to signpost people to, where the next point of call for their support, and also having that joint up piece of work. So we've done it. I can think of a few examples in my head regarding cases where we've had a joint up piece of work where we've continued working, for example, supporting a client in EWS while also getting a bit of support for maybe a medication review and ATS. So it's that kind of joint up piece of work which has been really integral for patient care. And I think that's it from me.
Fabulous. I am going to stop sharing now so that we can come together as a group. We've heard some great kind of presentations from Martin, Penny, Mary Linda and Susie, just giving an update on what's going on across the system, the actions that have been identified in terms of getting the teams fully mobilised, and then some brilliant examples of how things are working really positively in West Sussex. So I'd like to open up the floor for questions, and Penny's right there, right there. Over to you, Penny.
Sorry, it's not a question. Just before we continue, just if there are any acronyms that are being used that people don't understand, I've tried to put some in, but please do let me know and I'll add them to the chat or put your hand up or however it feels more comfortable for you. Thank you.
No, that's
Thanks,
a good
Penny,
shout.
for that. Sorry about my acronyms.
We do
We
work
all
in a
do it.
system with lots of acronyms, so yeah, that's a good shout. Michael, I'll come over to you. Would you like to ask your question?
Yeah, thank you. I understand that you're a group of professionals, and I do not wish to decry what you're talking about. And I'm not picking up on the acronyms either. What I feel is missing is, rather than a top-down perspective, can we have a bottom-up? So from patients' point of view, one of the things that kind of bugs me an awful lot is this idea that, we used to say, GIGO, garbage in equals garbage out. And it'd be really great to be able to feel assured that patients have a voice in correcting or clarifying records which have been entered onto the system, and bearing in mind that a lot of GP data records were handwritten, in a time when it was, computers were on the horizon or not even a speck in the eye. That information needs to be accurate and verifiable in being able to act and share within the NHS. If it's not, then you need to give a voice to the people who are being affected by the decisions based on faulty information. And without that, people will go, why should I share my data with the NHS? They're not trustworthy. I'll hand it back over there.
Thank you, Michael. Penny, have you raised your hand to respond? And
Yeah, because I think it's a really good point, and I hear that a lot. So it's not the first time we've had that kind of issue raised. Completely agree. And I think one of the good things about the progress is the real direction of travel of people holding their own records and accessing their own records. They are that individual's records, so they constantly see them and have them. And I think that's still our ambition, to work towards more and more people. And I know it's not everybody, but we can start with where we can do that in terms of all the digital tools we've now got, all the promotion of my health and care records, all of those things. I think we move culturally much more then to driving things being checked out with people because they're holding it themselves. So I do think it's a really, really good point. I'm not suggesting neighbourhood mental health teams will entirely solve that, but I think alongside using that more and more and more to be able to really make sure people can access everything. So there is nothing about me without me that you can't see. And then we have those processes in place, which aren't that easy. I understand that, but about challenging things where things might feel incorrect. So that feels really important. And I think your point about people speak in and come in, and one of the forums we'd like to do here is have a completely service user expert by experience led session describing some of the things that have been good, things that have been challenging, to really reflect that, because obviously we work with big groups of people with lived experience, but it would be nice to have some sessions in this type of forum where we can do both of those things. So I know that doesn't give immediate assurance, but I hope that helps describe some of that direction of travel. Because I completely agree, people should be able to see whatever's written about them because it's their information, and we're definitely going down legally down that pathway as well as kind of morally, which is helpful.
Thanks so much, Penny. I've definitely logged that it would be fabulous to have an expert by experience kind of individual who's receiving care led session for one of these webinars coming up. So we'll make that happen. Martin, over to you.
Yeah, that sounds like a great idea and suggestion around having that focus for a future webinar as well. I'm just conscious that Glenn's might be come in to pick up the point, so I'll probably just think about, or maybe just answer that, Michael, about that ongoing voice, I suppose, as well. So we are in very much of the kind of implementation phase of this as well. And we have done, many events, and we've, really tried to make sure we listen and respond to that as well. And there is a commitment to keep doing this as well, because we know that kind of that first sort of mobilization, there's still things we're going to have to be doing over the next sort of months and years as well. So there is going to be an evaluation kind of framework that we're going to be doing to really kind of review each one of the neighbourhood teams when they're up and running as well. And part of that is having kind of people with lived experience, whether it's the scale or the league, being actually part of that review process as well. So they will be kind of coming in and talking to staff and really kind of raising any, concerns, but also kind of really celebrating successes as well. So, I think we've done a certain amount as Penny. There's more we can do, but I think there is that longer term commitment to actually kind of making sure that the voice in this co-production way is meaningful and it is really sustainable as well. But some really good points you raised, Michael. Thank you.
Fabulous. Thanks, Martin. And Glenn?
Yeah, I have a new question. I'm not sure if you've wrapped this one up yet, and if you wanted to move on or if you wanted to stay on point, but are you happy for me to ask a new question?
Absolutely. Ask away.
I was interested in where SOAMs and people with dementia fit into the neighbourhood model, in particular into the new meeting structure, because I wasn't sure that I heard about them, and I'm asking because we are hoping to learn something in East Sussex so that we can follow suit.
Penny, would you like to respond to Glenn's question?
Yeah, Glenn, really happy to catch up with you also outside of here. But what they do is they come for part of most of those meetings. So they're not, a bit like the GPs, they're not sitting through the entire session, and they really think about who they need to, or which discussions need to take place at those particular meetings and agree it in advance. But I'll catch up with you about it afterwards if that's useful. But fundamentally, that's what they've done. Yeah.
Okay. So the meetings are happening, and SOAMs can kind of book slots and come to those meetings.
Yeah, so they come when they need to, as opposed to because still most of the work that needs expert older adult input will still need expert older adult input, and that we don't want to waste anybody's time, having to sit through perhaps quite lengthy meetings. So it's more about, I'm not sure where this care might fit, and we need to have some joined up working around it, so we'll have those discussions, and so that's why they've developed it in that way.
Okay.
Fabulous. Thank you. Does that answer your question, Glenn?
Yeah, I'm happy to catch up with Penny outside the meeting and get more details. I'm just kind of, I suppose I'm interested fundamentally on what is separate, what is combined. Do older people services have their own daily huddles that are separate to the adult mental health, or are they combined? Those sorts of practical issues really that we're interested in.
Yeah, fabulous. And if anyone else on the call is interested in that specific area around older adults, just pop it in the chat, and maybe we can focus on that in a future session, or kind of share some information after this webinar. I'll just come to a question that's in the chat and then come to the virtual hands. So, Corinne, thanks for your question. Penny, when you talked about lead practitioners, named person in the CPA, session of the presentations. Corinne wants to know, will patients be allocated a lead practitioner, and if so, in what instances?
Yep, certainly. So that's what we're working through now. So that new guidance is really interesting, and it uses different language. It uses part of the languages around key workers, and one of the other bits of language it uses in that draft guidance is around care coordination. And it talks about what type of situations either of those things may be useful with. So it's currently a work in process to work that through. We do have a CPA working group, which includes experts by experience, to work through the detail of what that will look like for Sussex, and that will then come out for consultation and discussion and comment, and hopefully make that clearer for people, because that's a really good point. One of the things people worry about is not having that role, a lead practitioner, a name worker, whatever it might be, a key worker, absolutely clearly described to them. So that's work in progress for now.
Fabulous. And there's a follow-up question around consent. So can patients being referred into a neighbourhood mental health team, can they refuse for information to be shared with SPFT in the meeting structure in MATS?
So this is a bit of a complicated answer, because it depends on where that referral comes from. So if you go to your GP and your GP, you have that discussion with your GP, the place where a secondary care clinician has expertise in triage is the next step that a GP might choose to send someone in. So in that case, no, because SPFT is the provider of that triage function. So of course we only share proportionate information based on need. But if you go to a GP and in your area you have an emotional wellbeing service, so you have a service that's run by the voluntary sector, they're working in partnership with SPFT, but in that first instance you can be referred to see that mental health support coordinator, and then that will be a discussion, unless of course the risk is very high and there needs to be an immediate discussion, as is the case now. But in normal circumstances there would be a discussion around that. Also in West Sussex, particularly in West Sussex or anywhere actually, if you go into a voluntary sector provider, they would have to have that discussion with you about whether you're wanted to have your needs discussed with Sussex Partnership. Sorry if it sounds complicated.
No, not at all. I guess my question was more, so maybe I misunderstood. I thought you were all going to be having the same systems, the same database, and whether there was a way of making sure that patients knew what part of that information they agreed to be shared. Maybe I wasn't very clear.
No, you're spot on. And one of the challenges now with the new electronic patient record system is because every neighbourhood team will have a single unit that we're working through at the moment is who can see what in that unit. So it would never be more than the core team of providers, which is majority Sussex Partnership Trust with commissioned voluntary sector partners. But we are working through what it means when that referral comes through. So one of the really important things for us, for anyone that's referred in, is they've got an information leaflet to allow them to make that informed choice about what that means, because it's a really important point. And so we've definitely come back to that.
Thank you.
Fabulous, thank you. Just a couple more questions in the chat and then we'll come to you, Jill. Thanks for waiting so patiently. Daisy, thank you so much for kind of sharing your concern around a feeling that the emphasis is going to be on short-term care, and that kind of acknowledgement that for some people having long-term consistent care is really vital. And Daisy shares that she's concerned that she's going to be discharged to meet targets and the effect that will have on her mental health. I don't know if Martin or Penny want to kind of respond to that.
Yeah, no, if I start, maybe Penny can kind of add after me as well. I think it was a real kind of we have kind of emphasised the kind of short-term care in those discussions as well, because sometimes we talk about how we're going to change the system in terms of how people come in, But I think we want to make sure that we are really mindful and really kind of thinking also around kind of the care people have once they're in that neighbourhood team as well. So we really kind of hear that, Daisy, and we also hear that from carers as well. So we know that people's kind of needs, might fluctuate or change as well. So we want to make sure that that is a safe and really supportive place for people. Some of the services you experience and receive now won't change at all, but there is an opportunity to actually kind of think about how services could work much more closely together as well. We understand that people's kind of mental health or mental health support needs may fluctuate. So there might be times that, that it's really good to get your support from kind of certain services or providers as well, but they are going to be more closely linked. So where there is times when people are kind of in distress or need more help, we are kind of making it kind of simpler to actually access that help and much more quicker as well. And I think in terms of what we don't want to do, we want to recognise where people are. We want to keep that kind of personalised tailor, so there won't be any pressure for people to move from one part of the system to the other around numbers or saving money as well. We kind of really want to be kind of respectful where we are. We kind of often talk about kind of safe transition. We know this is a really significant change of how we work together as well. So one of the things we've had running through this is around safe transitions, and that's from our individuals as well. So people's kind of current support and treatment won't stop, it won't be affected as well. We're really trying to build on sort of the opportunities available for people and how we make it easier for people to move from their support needs from one part of the kind of system and services. As before, you might have to wait, you might have to be re-referred as well. So we want to make that kind of cultural change for people as well. But again, we will be coming out and asking people, is it better? If it's not better, how do we make it better as well? And that's that continuous conversation that we really want to kind of have that open dialogue with people. But Penny, do please add.
Yeah, just to add that this whole programme is really focused, of course, on people with long-term mental health needs. And it's a really good and important point, Daisy. And it's really important to acknowledge that there will be people that need support one way or another from a bit of the system for long periods of time. And there is absolutely no focus on changing that at all. It is, as Martin's just described, just ensuring we make the best use of everything we've got. So at any point in time, that person's got the help and support they need within the resources that we have available. So the programme nationally describes itself as a programme supporting people, as I'm not sure about this term, but with serious mental illness, so long-term or complex needs. So we have to make sure we're constantly keeping an eye on that. And one of the really helpful things about working with the voluntary sector is that kind of working together relationship where perhaps some more clinical expertise is needed. It's easy to access and can be quick, but it doesn't disrupt the other person's life and all of the other support they're getting to get on with things. So it's much more about a continuum of support rather than having kind of sharp endings. We're also working with commissioners to make sure we're all commissioned to do the same thing. So there aren't those things that you describe about, I have to discharge X amount of people or Y amount of people, that we've got a shared agreement about what capacity and demand looks like, because it is a really good point.
Thanks so much, Martin and Penny. I hope that kind of responds to your concern, Daisy. So moving on to a question from Fraser, who's asking about the personalised care framework. Assuming that it replaces risk assessment, prediction, stratification that was included in the CPA.
There's really briefly, there's two kind of integrated pieces of work going on nationally. One's looking about risk, and there is the CPA. So yes, the two have a big interdependency, but they are being worked on, I want to say slightly separately, but I don't mean without the information about the other one, but by two different working groups.
Fraser, you've got your hand up. Is that to come in around the conversation around the personalised care framework?
Yeah, I'm kind of in the sense that kind of the guidance document from the NHS England that was published in April actually says that risk assessment should not be done, and echoes a NICE document from a few years ago. The CPA document does talk about risk assessment, as do other existing documents. And And just to feed back that during training on suicide prevention, one of the main complaints of GPs in Brighton and Hove is that ATS was rejecting referrals without risk stratification, i.e. against policy. So I'm just intrigued that kind of this means a pretty kind of major review of a lot of policy documents to make the shift away from this risk assessment to predict risk and stratification, which actually is proven to be hopeless, rather to risk modification with safety assessment and safety planning and safety management. As I haven't seen the personalised care framework, so I don't know whether that is taken on board. The NHS England guidance obviously is fairly recent, but the NICE one was from a few years ago. And that actually during trainings with GPs, kind of this is in Brighton and Hove, a lot of them are actually questioning us as trainers why we're even talking about risk assessment, because that's old hat and against policies. But it seems that ATS, listening to the GPs, are still insisting on risk stratification, and without that, they automatically reject referrals. So an entry point, there seems to be a bit of a glitch, which I hope the documents kind of address.
Yeah, it's a really good and complicated point. So there is still work around risk assessment, and at the group, in terms of the trusts that are working on that, are working with the latest national guidance. I've only been briefly involved in that group, but we could certainly ask someone to come back and speak to that. The referral forms that we're working on with GPs do talk about GPs' concerns, but they don't talk about doing a full risk assessment at that point of entry, if that helps, Fraser. But we could definitely come back to this discussion about risk, because it, again, a really important point, and we could certainly do that any future webinar.
Fabulous. Thank you, Penny. Jill, would you like to ask your question in person rather than me read it from the chat, or anything else you'd like to ask?
Hi, I think that Glenn actually asked the question that I was thinking about at the same time about, would we dip in and out of these meetings as we used to when I used to attend all the MDT meetings at GP practices. We used to look at any referrals then that we would discuss with the GP, and we'd say, yes, refer, no, don't refer. You need to do this first. And it would be, so much more fluid, really. But then we'd leave, because it would be then, the order of service, as it were, would be working age, older people. I know that we want one umbrella. However, not everybody can sit through everybody else's referrals, and it's a terrible waste of money, people's time, and it's inefficient, isn't it, really, in my opinion. So that was one thing, but I think Glenn already talked about that, and you're going to talk some more about it for older people's. Regarding the GP referral forms, because that's always been the thing as well that we've looked at and have thought about. One line isn't enough. Narrative is always better than even having risk statements. Narrative's always better. But one of the big problems that we've always had in older people's is when we are sending a referral back saying, no, it's not adequate and we don't have the physical stuff. But we get a lot of referrals from people that send things in, paramedic pracs, for example, send lots of referrals in, and then we can't get hold of them. And I feel it should be by law that they put their mobile number there. They can ring any of us so that we can phone them and say, can you clarify this? And then we can move forward. No, leave messages for that person to get back to us, and it never happens. And those little things like that are such a frustrating part of everybody's day, really. MDT, GPs, I said that bit, and I've written down here about confidentiality as a question, only because I'm just unsure about all of that, really. I don't know if you've touched on it in other webinars, but it's not clear to me, really.
Yeah.
And again, going back to people with dementia consenting for open forum for their discussion, for example. Is that right? I don't know if I'm using the right words.
Thanks, Jill. Penny, do you want to come in and respond around the consent?
Yeah, certainly. Yes, it's a really good point around consent. We're definitely having conversations with the leads for older adults within the organisation to look at what they do already. So at the minute, when someone's referred that particularly cannot give consent because of cognitive impairment or any other reason, about what we then do, and we're going to add it to the kind of standard operating process to make sure there's copy across about how we work those things out, and including how we get consent to discuss people in a multi-agency or multidisciplinary team, because it is a really specific and important issue. So I haven't got an immediate answer for you other than that's a live topic with the older adults leads at the minute, and a really, really good point. In the context of information we can see and information we can't, one of the advantages of the new electronic patient record is the information that we can access, providing it's stored on those records. So we don't have to say, sorry, we can't take this referral, because actually we could already see it. And we know we can already do some of that through something called Plexus, which is a system that's been through a safety procedure that allows Sussex Partnership to look at certain parts of GP's records.
Yeah, we do
system, that. System one will only improve that ability to be able to share critical information and process things quickly. It won't solve everything, so there will all. It'd be good, Jill, if you continue to raise those specific issues you have around things like paramedic pracs, so we can then look in the optimization part of the EPR about whether there's anything we can do to mitigate it or make those things better.
Thank you.
Fabulous. Martin, did you want to add to anything Penny said, or have a question?
Yeah. No, I don't have a question, but I think it's just adding to that, really, isn't it? It's like I kind of visualize the kind of conversations around confidentiality and consent. It's like a seesaw. They're really, really important, and we have to kind of tread carefully. We are making sure more that we have a very open and transparent conversation about the process, the opportunities we want to build in. Opportunities across everybody's course, support and treatment kind of care. There's opportunities to review their consent, to change it if they need to as well. But I think the kind of the seesaw part of it, if we're going to work in a very different way, if we're going to have coordinated conversations and kind of mechanisms and meetings that really do support joined up working as well, we do need sort of an element of kind of openness and transparency as well. So we've got really good examples already of that working in West Sussex. So say for Susie's team in BHT with mental health support coordinators working really closely with GPs, but also Susie's services also have housing support kind of attached to their kind of organisation as well. So they could be a great conduit for actually having a joined up conversation and saying, actually, let's kind of work that person might need around kind of specialised treatment, but actually my kind of organisation could really help that person with their kind of their housing situation or their kind of their financial situation as well. So we're just trying to get that right balance, isn't it? That we really respect people, privacy, right to own their own data as well, but working in quite a different kind of way as well. So we want to make sure that that process is carefully done, but we're trying to get that right balance constantly as well.
Fabulous. Thanks, Martin. Michael, we'll come to you, and then I'll go back to the thread and just respond to Matthew's comment around referrals in West Sussex, and maybe Susie and Mary Linda can come in and respond to that. But first, Michael, have you got a question?
It's not really a question. It's more an opportunity to introduce myself. And I'll keep it as briefly as I can. I'm a governor for Sussex Community NHS Foundation Trust, and it's a very new thing for me, a couple of months. The other thing was I'm also part of Brighton and Hove Older People's Council, so I've been really interested in the whole discussion. So if anyone wants to pick up and engage further around that, please do not hesitate. You'll see my NHS email address on the website for the Community Foundation.
Fabulous. Thanks, Michael. Are you happy for me to pop your email address in the chat,
Yep.
or you can pop it in while we're having a conversation? I think that's great about these webinars, that we can get to know one another. So please don't apologise about introducing yourself. That's what it's all about. We've got a comment from Matthew just in the chat about not really kind of seeing a difference, noticing a difference around referrals for people moving between services in Crawley. So still needing to ask GPs to refer people to the assessment and treatment service or the emotional wellbeing service. I know it's a slightly different area to Mary Linda, but Susie, would either of you be able to comment on that?
I think the main thing here is the fact that we are still in the developmental stages of the NHMTs across West Sussex and Sussex. And the main barrier at the moment is the fact that we are currently on different systems, and getting that link up to with regards to the paperwork and making sure that the patient's not lost in the system, that everything's where it needs to be, consent, confidentiality. Before we are all on system one together, where it will be far easier to, refer and everyone can have access to it. I think that's what our main barrier is at the moment, while we're through these kind of developmental stages. I don't know if you also wanted to add anything else as well, Penny, with regards to where we're at with kind of like the SOP, maybe? Yeah.
Yeah, I can. Yeah, I can. So what's slightly tricky is we're trying to bring services together, but they're all currently commissioned slightly differently. So we're trying really to bring all these bits, which is why it still feels a little bit clunky, I suspect. And we hope at some point to become kind of a whole commissioned NMHT, which will make all these things much, much easier. The reason that you might be experiencing that still in Crawley is because some GPs and some primary care networks have chosen to fund a clinician which supports an emotional wellbeing service, which has voluntary sector provider partners within it, and some haven't. And we don't have, there's no obligation for GPs to use some of their money, and they're called R's roles, additional responsibilities roles, and to fund those for mental health. So it's quite a challenge to make a kind of whole system discussion about how you manage that front door, how you manage things coming in. So what we've tried to go for to try and mitigate some of this for now is, even if somebody goes to either an emotional wellbeing service that where it exists in GP practices, or they come through to what at the moment's called an assessment and treatment service, that multidisciplinary meeting, a multi-agency meeting, is the space where we can try and work out whether we've got that right and whether we need to have further discussions around those things. So the standard operating process will help with that. We've had a first stab at getting that out to everybody and had lots of feedback through, and we're now thinking about how we utilise that between now and when we've got the new electronic patient record system, which will change things again. So it's a bit of a balancing act to get those two things right. What we are doing over the next few months is working with our colleagues in primary care to discuss the very point that Susie's talking about. Where that system exists, would it be better for a GP to be able to just say, I'm making a referral? And no, that could either be for that emotional wellbeing element, so that voluntary sector supported by a clinician, or the more or people with more complex needs who need clinical support and intervention in one space, and we're then able to use the system to allocate tasks in a different way. Because my understanding, I'm not technical, but my understanding of our new record system is that we'll be able to have a task come in really from a GP saying this is a referral, and be able to task it to different bits of the system to say, okay, this can go to someone in Susie's team, or this needs to go to have a discussion about clinical triage. So that's why we're not quite there yet in terms of those processes, and that's why they feel, as I say, clunky, but we will get there, and we will continue to do the best we can in terms of making sure those multi-agency conversations take place as quickly as possible while those systems are separate. So it's not an immediate answer, but it is a really good point, and something we continue to work on.
Thank you so much, Penny. And we've come to 1 o'clock, so I'm going to draw the conversation to a close, but just wanted to say a warm thank you to all the speakers, Penny, Martin, Susie, Mary Linda, and everyone for getting involved in the conversation. With all the questions, there's clearly lots of interest and there's loads of work in progress. So do keep involved and keep coming along to these webinars where we'll continue having a conversation. There's also a monthly newsletter that goes out, so sign up to that to keep up to date. I'll pop links in the chat so you know when the how you can subscribe to the newsletter and register for the next webinar, which is on the 11th of June. But for now, have a lovely rest of the afternoon. Thank you for attending, and I'll see you soon. Take care. Bye.